go ahead and get started. Today we're going to have a presentation by one of our clinical informatics fellows and one of our clinical informatics department faculty on sprinting towards better clinician engagement. And I think they're going to talk about some work that's going on in the clinical enterprise. Most of you know Brian Tran, who is, I guess, are you technically second year now, or? Technically, okay, technically still a first year clinical informatics fellow, but not for long because he started, when was it, last April. And Bud Garrison, who is a faculty in the program and works in the clinical informatics department in the hospital. He also is a graduate of our graduate certificate program, right? Did you? No, you didn't do. Oh, you did the. Yeah, I started with the HIM graduate. Oh, that's right. Okay. But I am a graduate of the School of Medicine in the MBA. Okay, great. Okay, great. Anyways, and I don't want to set a bad example, but I actually have a meeting in the dean's office at 11:30, so about like 11:22 or so, I'm going to quietly exit, much to my disappointment, but the dean's office has to take precedence sometimes when they schedule meetings. So, okay, Brian.
Joining us today, and again, my name is Brian Tran, I'm one of the Informatics Fellows. Today we're here to talk to you about sprints and how we're using sprints to address clinician engagement. Again, I'm here with Bud Garrison. He is one of the directors of clinical informatics, and he's been tasked with bringing sprints to OHSU specifically to address clinician engagement. So just a quick outline of our talk today. We're going to be talking about sprints. First, we're going to give you guys an introduction to what sprints are, discuss clinician engagement, how we're using sprints at OHSU, and then we're going to give you a couple examples of how we've used sprints to address certain issues that we've come across in the clinics. First, what I'm going to do is I'm going to play you a short YouTube video just to bring us all up to speed on what sprints actually are.
To our sprint process. The big idea with a sprint is to build and test a prototype in just 5 days. It's kind of like fast forwarding into the future so you can see.
This works. Nope. Here we go.
Hi, I'm Jake from GV, and this is a super fast intro to our sprint process. The big idea with a sprint is to build and test a prototype in just 5 days. It's kind of like fast forwarding into the future so you can see how customers react before you go to all the time and expense of building a real product. Every sprint starts with a big challenge, a team of about 7 people, and a clear calendar. On Monday, you'll create a map of the problem and choose one specific target. On Tuesday, you'll create solutions to your problem. But instead of a shout-out-loud group brainstorm, you'll work alone to sketch detailed, competing solutions. On Wednesday, you'll pick the best solutions. Instead of endless debate, you'll use a structured decision-making process. On Thursday, you'll build 1, 2, or even 3 realistic prototypes. These prototypes are just a facade of a finished product. You can use tools like Keynote, Marvel, and Envision to create fake apps and websites, or to quickly prototype hardware, you can use a 3D printer or modify an existing product, or just prototype the marketing materials. Finally, on Friday, you'll test your prototypes in 5 one-on-one customer interviews. You'll find obvious patterns. Some solutions will work, but some won't. Either way, you'll have clarity about what to do next and a great start on that big challenge. To learn more, check out our book, Sprint. It's got detailed hour-by-hour instructions, and it's packed with stories about startups like Slack and Medium and Flatiron Health. Good luck with your sprint, and thanks for watching.
So that's a general introduction to sprints. So sprints are short, time-bound events where we have very defined tasks, and the goal is to implement very short tests of change and adapt very quickly to the feedback that we received from them. So from this graph, we're seeing we have an idea and we're testing it and we're adapting on the fly rather than spending a lot of time building and implementing things. So sprints in healthcare. Sprints have been used generally in the technology field, and we've seen them as a basis of agile software development. When it comes to healthcare, a place like the University of Colorado has actually implemented sprints, and what they've done is they've used 2-week time-bound rapid process improvement events where they're targeting very small but meaningful issues in clinics, and what we've seen is they've actually been able to make some pretty dramatic outcomes with that. So the model that the University of Colorado has used, they've done 2-week sprints. They have a team of 11 physician and nurse informaticists, Epic analysts, and also their CMIO. They go into the clinics and they've done rapid cycle workflow improvements as well as targeted EHR training. And the important part of this is their outcome measures are they've reduced provider burnout, improved access, improved charge capture, and also improved quality metrics. So they've actually pretty much addressed the quadruple aim by implementing sprints. And one of the interesting and timely takeaways is by targeting EHR training and improving workflow, they've been able to reduce provider burnout. A lot of the data that's coming out about provider burnout is showing us that upwards of 30% to about 50% of providers are reporting burnout across subspecialties. Some of the subspecialties that are more burned out are primary care clinics as well as urology and neurology. When asked, providers believe that things that contribute to burnout are charting, using the EHR, as well as interactions with members of the care team. And what we've seen is a lot of the studies have been trying to address these issues. Tate Shanafelt, who's the chief wellness officer at Stanford, he's published widely about provider burnout, and one of his assertions is that clinician engagement is the positive antithesis to burnout. Clinician engagement is characterized by vigor, dedication, and absorption in your work, whereas burnout is the opposite, where it's exhaustion, cynicism, and reduced effectiveness. They've also published organizational strategies to reduce burnout and promote physician engagement. Among these are acknowledging and assessing the problem, developing and implementing targeted work interventions, and cultivating a community at work. Studies at OHSU have actually studied clinician engagement, and they've distilled the recommendations down to 3 things that should improve clinician engagement here at OHSU. 3 things are improving clinician satisfaction, fostering communication with clinicians, as well as developing clinician leadership development. From the framework that we've seen from the University of Colorado, the goal is to use sprints to provide targeted EHR training, addressing clinic-related frustrations, and at the same time measuring burnout with the Maslach burnout inventory. With the targeted EHR training, what we're trying to do is identify gaps and increase proficiency in the tools that we already have available to us. When it comes to addressing clinic-related frustrations, as we'll soon see, there's a lot of crossover between what between the contributors of burnout, and when we're addressing these clinic issues, we're looking at them in terms of people, processes, and platforms. When we're providing targeted EHR training, there's something in Epic called the Epic Provider Efficiency Profiles, and it has 3 main components. One is EHR proficiency. So this is how physicians use customization and efficiency tools. There's also the Provider Efficiency Score, which outputs a calculated expected versus actual time in the EHR based on provider workload. And then you can also drill down in terms of how the providers use the system, specifically time spent after hours, time spent in their inbox, what the message turnaround time is, and also percent of same-day chart closures. And the goal is to have a physician informaticist review a clinic's PEP or provider efficiency profile, and then provide targeted training during the sprint process. And some of our future directions that we're hoping to integrate into the targeted EHR training is correlating the metrics from the provider efficiency profiles with burnout, specifically answering the question, does lower proficiency correlate with increased burnout? And if we address EHR training, can we also address provider burnout? One of the things that we're also working on is using REDCap to capture pre and post results of the Maslach burnout inventory after our interventions with the targeted EHR training, as well as addressing the issues in the clinic. The next component of our sprints is to address clinical-related frustrations. And as part of the sprints, a survey goes out to the clinic staff and providers where they basically provide feedback in what issues they're experiencing. After feedback is given, the responses are displayed in the clinic, and the staff are able to vote and prioritize which issues they'd like to address. We're going to go through a few of the issues and how we've addressed them. One thing to note is, as I mentioned, we're looking at them in terms of their processes, the people, and the platforms. And a lot of times when we're looking at burnout, people say, oh, it's the EHR that's causing us to have burnout. But one thing that we saw when we addressed these issues is it's not just the EHR, but it's the context that these issues are arising and the context in which they're using them. So without further ado, we're going to look at one of the issues we dealt with in neurosurgery clinic. So one of the issues where pituitary questionnaires are too lengthy and redundant. Patients are tired of filling out the same form every visit, and it takes up a lot of MA time to enter everything. We looked at the actual forms, and they were paper forms. They were 5 pages long. And one thing to note is they used the same form for every pituitary patient. What we did was we scanned in the form, and I just tagged what each section was. So they have the allergies, the medication list, past medical history, past surgical history, social history, a general review system, and then a pituitary-focused review systems. And for any of the clinicians here, you could tell that some of the stuff is from the H&P, and this is things that may or may not need to be addressed on every single visit, but this was a standardized form that we used. So when we talked to providers, what the providers told us was that they didn't really rely on this information because it was rarely completed prior to the clinical encounter, and that they would ask these questions anyways, even if they didn't have this form. When we asked the MAs about how they use this form, they said that the pituitary symptoms section of this questionnaire was transcribed into a flow sheet, but because of the time that it took the patients to fill these questionnaires out, they would usually do it after the encounter. And then the entire 5 pages were scanned into the patient's chart. So just to summarize our findings, the questionnaire was redundant. Many of the questions that were also addressed at the MA in a general rooming workflow, such as reviewing their medications. The same questionnaire was used for both new patients and established patients. Once we have their past medical, past surgical history, generally that doesn't change from visit to visit. The questionnaire was also rarely completed prior to the clinical encounter. Also, the pituitary symptoms only offered same, better, or worse. And so if a patient had new symptoms, this was either written as worse or not at all. So here's a swim lane diagram of what the workflow is like. So the patient checks in, they receive the questionnaire, and because of the length, it took them pretty much the entire encounter to complete it. They would then give this form to the MA. The MA would enter the answers into a flow sheet. They'd scan the paper copy, and none of this information was actually relayed to the provider. So our tests have changed. So first what we did was we created 2 separate questionnaires, one for new patients, which did include a lot of their pertinent past medical history, past surgical history, current medications, and then we also had an established patient questionnaire, which was only the pituitary symptoms, which went from 5 sheets down to 2. Another thing we did was we added a new field on the symptom questionnaire. So here's the original, where you see there's check boxes for same, better, and worse. And the new and improved form now has a section for new. So if they did develop a symptom from the last visit, the provider could quickly look at that and address that. Another thing we implemented was modified workflows, and we encouraged the MAs to transcribe the pituitary questionnaire into the flow sheet as part of the rooming activity, and with a reduced length in the questionnaire that was actually able to be done. So this is our new workflow with our test of change. So patients check in, they receive their questionnaire. Because it was only 2 pages long, they were able to quickly submit it. The MA takes it. They enter in the answers into the flow sheet as part of the rooming process. When the provider comes to the room, they actually have all the information ready for them to review and address. So outcomes. The pros were we established patients were able to complete the form prior to the rooming process. Relevant pituitary questionnaire symptoms were queued up for the provider to review, and it also decreased the need for scanning documents. Some of the cons that we came across were the formatting of the flow sheets were not optimal for inputting into progress notes, and actually led to some note bloat, which is something that we're going to address on our next iteration. And our next steps around this is MyChart questionnaire possibly, with the idea of allowing patients to complete questionnaires prior to their appointment. There's actually been a debate in terms of the usefulness of MyChart questionnaires, and questionnaires that are sent out at the time of the appointment being placed may actually be 3 or 4 months out, and just the temporality of it may not make it relevant for when the patient actually presents. Also, not all patients have MyChart, so because of that, we may actually be supporting 2 workflows rather than 1. Another next step is to optimize flow sheets for documentation. We're looking at different vehicles to actually implement the questionnaire, just to ensure that the note bloat is not an issue and we're not contributing to worse EHR habits. Any questions about that? No. Okay, so the second issue we addressed was from neurology clinic. We had a number of issues surrounding communication between MAs and providers. The actual quote is communication between MA and providers about room and patient status, clinic flow of communication, running around whole clinic to find people. So when we did our workflow analysis, we identified the problem as such. There was only 3 to 4 medical assistants for about 15 to 17 providers for any given clinic session. Providers also had a very varied schedule that would change week to week, day to day. So an example, one of the doctors would be there on the 1st and 3rd Wednesday, and then again on the 1st, 2nd, and 4th Thursday, which made it difficult to anticipate where they were. And because of this, the MAs actually changed the way they assign themselves. They did their assignments on a first-come, first-served basis for the patients, and so they weren't actually assigning themselves to providers. And why that was a problem was there wasn't communication, and providers would not know who was rooming their patient, which we identified as probably the root of the communication breakdown. Another contributing factor was providers had different needs depending on their subspecialty. Some of the providers who had procedures would need like a 10 to 20-minute MA commitment. Other providers only needed 2 minutes to room their patients, and so depending on which clinic you were covering, rooming a patient might take 20 minutes or might take 2 minutes. And the MAs knew which providers were requiring which, but it varied pretty much patient to patient, day to day. So to summarize, the issue was unclear MA and provider assignments. Providers were unable to communicate with the MAs because they did not know who was rooming their patient. So our test of change was to assign providers to MAs per clinic block, AM and PM. We had assignments that were done on a daily basis. They were written on the wall in the MA workspace as well as in the provider workroom. We also had the MAs team up into like a A squad and B squad, so they would always have coverage, and there would be assigned coverage, so they knew if they were stuck in a room doing a procedure that someone else would take over for them. And then one aspect that they really liked were the teams were able to cover for each other for lunch. Before, if things got busy, they would either skip lunch or take lunch at 2 or 3 o'clock when things calmed down. But by having this this team, there was an expectation of having coverage. The feedback we received was it did improve communication. MAs liked it because there was a mechanism to cover for each other. Some of the cons were the daily MA to provider assignment took almost an hour to complete on a daily basis. And the reason being, where the MAs would do this manually, they would open the next day's chart, and they were trying to distribute patients to ensure everyone had an equal distribution, make sure that everyone had a variety to different exposures, to different subspecialties, as well as account for add-on providers. So sometimes a provider may say, oh, I need to see a patient tomorrow, and then just show up, and that would kind of throw everything for a loop. Each clinic had upwards of 100 patients, so dividing this between 3 or 4 MAs, looking at all these different variables was very time-consuming. What we ended up doing was we looked at some data. NatFam and I actually pulled up the department appointment reports, and from there we were able to see when providers showed up for a couple months back. Based on that, we were able to come up with a estimated time of what the schedules would look like. So we presented this to the MAs, and we said, you can do it manually, or we can actually have this estimated schedule where everything would be predefined. And initially they were skeptical, and what they did was they would do the manual schedule as their gold standard because they knew that would keep things fair, if you will. And they also looked at hours, and we found that our schedule based on data got them about 80–90% there. And so it would actually improve their time by from an hour to about 15 minutes. So our outcomes were we were able to reduce the time to create the MA and provider assignments. The cons were it didn't really account for the add-on providers, and if there were add-on providers, that was something that would have to be addressed at the daily huddle. And patient assignments weren't equal on a daily basis, but what we figured was if you stretch it out over a week or a month, they should even out. But if someone was seeing 15 patients one day and your colleague was seeing 18, we can't really account for that if we're guesstimating things. But one thing that we learned from this is a good example of not letting perfection be the enemy of good, as it got us to 80–90% of the way there, and it didn't require someone spending an hour sitting there and manually tallying patients up. And as we mentioned, the next steps we're using the daily huddles to review the patient assignments, add-on providers, and making adjustments from there. But at least they had a framework to go off of. So conclusions from our sprints is taking a social technical approach is important. A lot of the issues that we looked at were not just about the EHR. A lot of them were about people, processes, and the platforms and the contexts that these issues were in. One other thing we talked about was some of the clinics, they had very similar issues, but we took different approaches for each one because of the context in which those issues lied. And also, provider engagement is crucial. And as we're going about this, it's still a bit of an issue. And me and Bud were talking about this before, saying that we can't really improve provider engagement if all we do is address MA issues. Future directions, as we mentioned, we're planning on correlating the provider efficiency profiles with burnout, looking at what's the impact of targeted training, looking at EHR proficiency in the setting of burnout, and also using REDCap to capture that pre and post intervention. And then the goal from here would be to bring sprints to all OHSU clinics. Any questions? That's it.
Thanks for sharing that. You mentioned at the end that a lot of the impacts, that a lot of the impacts were on the MAs, and the question of kind of the relationship between the MAs burnout and turnover with the clinician burnout. With your survey, are you doing the burnout inventory with both the clinicians and the MAs, or
yes,
is everybody?
So all the clinic staff take the Maslach burnout inventory. But in terms of the provider efficiency profiles, those are only for the providers. But we're looking at burnout for everybody across the board.
Right. I guess what I mean is that even if you don't see a drop in the burnout inventory for the clinicians in the short term while the MAs might have better results? Are there other metrics like turnover and things that eventually over a longer trajectory would play into how the clinicians feel about this, even if that short-term improvement doesn't trigger the kind of score drops you're looking for?
So comment on that. We're now just wrapping up our 4th sprint. So to give a little history, we did 2 of these last year as a pilot project. In that pilot project, we initially just sent the Maslach to the providers, right? And kind of realizing and dipping into a little bit of your questions, we decided, well, number one, that needs to go to all users. And then, of course, not thinking that through wholly, right? About our 3rd one, we said, oh, wait, we ought to maybe need to identify in that survey, are you an MA or an RN or whatever? So it's been a little bit of an evolving survey. We do now have a role-based in there where the person can pick their role, and we're tweaking that role a little bit depending upon the practice that we're looking at. Our next clinic is going to be the Comprehensive Pain Center. They have a lot of alternative therapies going on. They have chiropractors and acupuncturists and massage therapist and several other things involved in that clinic. So we wanted to break them out. But then also you kind of have to look at that if you're going to keep the survey truly anonymous about how you label those roles. So if you say, well, are you a chiropractor and you only have 2 in the department, you kind of figured out, right, who's answering. We did also allow in that survey recently that people could identify themselves if they wish to. And then also in that survey, in the pre-survey, is a way for them to bring up those daily frustrations in their workday that we want us to tackle. And that's the other comment that I wanted to throw in is this is funded under the Clinical Engagement A3, which is an institutional program to focus on provider and clinical user burnout. What we've seen, and I think Brian mentioned this, out of the studies, multiple studies going on around the country, is the way that we reduce that burnout is long-term. We address frustration in your clinical workday, communication amongst your clinical team, and trust and leadership that we're giving them tools to do anything about number 1 and number 2, right? And initially, we do surveys on what's your frustration in your clinical day, and they say Epic sucks, right? That's what you hear, right? Long term, when you really look at the data, what you find is it isn't necessarily all tied to the EHR. So in these 4 sprints that we've done, we've had roughly around 200 issues brought up from frontline clinicians and staff and clinicians and faculty. I've been meaning to do the numbers on this, but I think if I go through that issue, I think in just looking at it quickly, my guess is less than 4% of those are directly related to the EHR. Now, we have a lot of EHR impact with those operational things that we try, but both of the issues that were brought up here, they had impact on the EHR. They weren't primarily EHR issues, right? Same thing that's being borne out in multiple studies, University of Colorado, University of Kansas, several others about burnout and how we impact that burnout. So what becomes really, really important in this process, and what we try and reiterate when I go to set these sprints up with the practice manager and the medical director and the chairs and then go to faculty meetings, is to say what we want to bring forward is what are the frontline faculty and the staff frustration in the clinical day, right? What is that pebble in the bottom of your shoe that's just annoying but not annoying enough to quit hiking and take the pebble out? So we're here to take the pebble out of the shoe. So tell us what the pebbles are. And we do a multimodal approach to collect those frustrations in the user's words. And that's really critical, I believe, is that we raise those up in their words, and we may group them together in themes, but we still address them and report back to them in their words what they brought up as being an issue, what they as a group prioritized for us to work on, and then what they as a group came to the table to develop solutions to fix, right? Because if we do anything other than that, if we take all of those and we state them all in our words and combine them into themes that we think are important and then hand them back to them, it's nothing more than, hi, I'm Bud, I'm from the government, I'm here to help, right? And it doesn't truly specifically, discreetly address their frustrations in their day. So I just wanted to throw those little comments in. I'm happy to answer any other questions.
About staff feeling empowered or maybe accountability for how the operations actually go. It sounds like you're stepping in and filling a gap there because people aren't apparently finding ways to address their frustrations on their own. So you're addressing that gap, and it's so exciting to hear about the work that you're doing. How will you empower these groups to continue this after you leave? Are you adjusting like the accountability or roles in the clinic so that it has like a long-term effect and they kind of take this as a springboard to go, oh, hey, let's keep doing this in all areas of the clinic?
I think part of what we're trying to do is actually give them the mindset that they can do this. And for every issue that we've actually addressed, we've asked them, how do you think that we should fix this? What do you think is going to work? Rather than, I mean, the issues that we brought forward, we didn't say, hey, you should do this. We said, hey, how do you think we should improve this? And yes, we may have had suggestions, but we're modifying everything based on their feedback. We're not saying you have to do this. And I think, like the MA stuff, they came up with a lot of that themselves as well. And as they kind of gave feedback and said, hey, this is not working, we should do this, we did actually move towards that. And every day we just kind of touch base with them. How do you think this is working? What else do you think we could do? And Bud, as the sprint master, if there are barriers, then they'll try to knock down those barriers. If there's something like, hey, maybe we should try Voceras, or if we need technology, we'll go get those, right? But I think one thing that Bud always tells them is the whole point of this is to show them that they can do this, and they don't really need us to do that, right? It's like Dumbo with the little feather, right? You've always had it, now you can do it. We just have to show you that you can. Yes.
Yeah, and that's really not the stated, but certainly the underlying goal, right? Is our goal with this whole program is to instill that mindset that they should incorporate this into their daily work. It is really interesting, though, and it's been interesting for me over the last 6 months, kind of starting up and getting into this process. Because, you know, we've had the lean culture around here at OHSU for quite a while, and that takes on a different path in every organization. The lean, so lean process improvement. So here we call that OPEX, or the OHSU Performance Excellence System, I think is what it's called. I've been to way too much training on that, so I should probably have that ingrained in my memory. But so that is lean methodology, the lean process improvement coming out of Japan in the, 60s, I guess, and 70s. Continual process improvement is really what it is. And how do we go to the front line of the work and we make sure that our users on the front line have it ingrained that part of your job is continually improving the process of how you do your job, right? Which can be really tough in a clinic that has 17 providers, only 3 MAs on that day, and 110 patients to see, right? So how do you get that ingrained? And that is definitely one of our goals is to get that. And now back to, I'm sorry, I don't know, back to your comment or your thought about long-term cultural change and long-term change in the burnout. What we've seen in the literature is that this sprint, us going in and doing 1-2 week sprint in a clinic, it helps about that much, right? But we don't see cultural change and reduction in burnout until we're through a second or a third phase of this. That's kind of what came out of University of Colorado. but it is that long-term mindset change, because that increases, the more that they can see, everybody can see, that we're focused on this issue and that we're bringing tools to truly help, the more you increase the communication amongst the team, the more you increase the trust that leadership understands the problem and is putting tools in the hands of the users to reduce that, to improve their work and reduce their burnout. And that's where we see the change. So this isn't a silver bullet. There is no silver bullet to anything, right? But it is a way to long-term affect change.
So you guys have a limited engagement time with the clinic that you go to. I know that you have an extended planning process, and then there's a post engagement process also. But to me, it seems that the real wild card here is the variability of practice that you will see in individual clinicians when you actually go to the clinic. And since these kind of variations in practice of especially physicians can be pretty significant, how do you kind of plan for that so that you actually have time to address individual concerns as opposed to trying to make workflows, processes better for teams? And then
Very good point. So what we're doing, our team that we bring in consists of, at the moment, myself as sprint master, right? So I'm running the process. And then we have a clinical workflow analyst out of our Epic Informatics specialist team. We have a performance or a process improvement consultant. I keep calling them performance improvement consultants, and they correct me that they're there to fix a process, not make people perform better, which I think is important. So, so we have a pick from our ambulatory team funded under the OPP. So they are very plugged into the overall standard work that's developed to standardize operational work across MAs, across schedulers. So when we go to look for a solution, what we're doing is, first of all, we want to refer back to the standard work that's being developed to standardize operations across the university. So if they say, hey, we have a problem, we're not using the dots in Epic to communicate patient status or provider status consistently across the clinic, and that's come up in 3 out of the 4 clinics, we say, okay, let's go to the standard work that's being developed, and here is the standard that you should be using. Now, anytime you put standard work in, and this is a very much a lean or a continual process improvement methodology, right? You developed your job breakdown and your standard work of how you want the work done. You always need to put the process together to inform that standard work of when you need exceptions. So we bring the standard work forward. We say the first thing we're going to try as a solution to that problem is we should try the standard of how we want to use dots across the enterprise. Now, if we come up with a reason why that won't work in this specialty and in this clinic, then we'll make sure we have the people there to make sure that we inform that standard work and either do an exception to standard work or inform and change the standard work so it's more broadly useful. So that's kind of one example about how we're trying to not over-customize operational processes. Now, when we get into the actual clinical process and clinical practice of the provider, we try not to touch that in this process. So once you get the provider into that exam room, except for some of the exceptions, like the pituitary questionnaires is a very good example of that. When that was raised up as an issue, this is why we love having our informatics fellows involved, because now I have an MD that can go sit down and talk to an MD about the clinical use of these questionnaires and what value is it. Now, I'm not an MD. I've been around this environment since I was like that high. But however, I don't have the credibility of Nat or Brian or anybody going and sitting down from a clinical perspective and addressing that. So that's why we have an MD on the team, and why we need to, that's one of our early lessons learned, is we need to have an MD and clinicians on that team to be able to affect that change. But one of our stated goals of this that I talk to the practice managers and the medical directors and the chairs when we go to set up a sprint is the one thing we want to respect and not touch unless you tell us to, is that provider to patient interaction, that provider to patient time. Did that kind of answer the question? Probably more than you wanted? Or, yeah, okay. And I want to make sure we get your question in, because you kept trying to raise your hand.
I mean, I don't know how big of a question it is. Is something that you want to see something where they're, not only do the providers gain the sort of agency and they gain the sort of empowerment that is so important for preventing against burnout, but in some cases they may not start out with the tools that kind of informaticist brings in, with being able to program, for example, and create those estimated schedules. Are those skills that you kind of expect teams or clinics or hospitals to start building, like long term, or do you expect them to keep needing to bring you in or bring in some sort of informaticist from the outside or some outside consultant in order to get those tools made once they identify their needs?
Yeah, and that's an interesting problem about how much do you resource individual clinics for that build work. Is that kind of that? And boy, that's a struggle, right? Because the problem is, the more that I take a build analyst, especially to build within the EHR, the more I put that build analyst siloed in a clinic, the more customization I end up with that's not necessarily long-term supportable or that meets standard work that we're trying to bring to the table across the organization. Does that make sense? So there's a little bit of almost a slippery slope, that if I go too far down empowering clinics to do their own building, do we go over that customization too far? So one of the things outside of this process that we're in the process of implementing is a wider use of physician builders across the institution. So Physician Builders is a program put out by Epic where I can have identified physician informaticists or clinical informaticists where we send them back to Epic for training. A lot of our fellows have already gone through that program, that they go back to Epic, they get a training in how to build certain user-facing tools within Epic. And so we've changed our physician informaticist support model to be a much broader specialty. So we're funding more providers for less amount of time than we have historically, so that they can go get that training and then they can represent their specialty knowledge and help build those tools, but also be plugged into a governance structure that makes sure we aren't stepping too far down that customization road. If that makes sense. Because, you know, you get too far down that customization road and your enterprise reporting just blows up, right? If you have internal med, family med, cardiology, all reporting differently on metrics about how they manage cardiology patients, good luck reporting on it, right?
I was just going to piggyback on that. I think, you know, as I'm a physician in training, and I think, I don't know if if the room agrees with this or if you agree with this, but I think that you had the list of 3 things that contribute to provider burnout, and one that I think was sort of was brought up, but maybe not explicitly stated, was this idea of like mastery and learning, and having that be something that is, I mean, communication is there, but I think that's a little bit more broad than this idea that, like, without that, like, concept of mastery and building and learning, that and feeling like you're having empowerment too, but really like getting better at something. I think that that's sort of another one thing that you might consider in framing burnout.
But then, Brian, this is very interesting. My question is, how much do you think you can take from one clinic and quickly disseminate it in another clinic? Because I know there's so many clinics that you guys are targeting. And for example, this MA scheduling issue, would you expect that you can use the time that you spent in the neurosurgery clinic, you can use the outcome that you had in different clinics?
So there's another example we didn't really touch on, but there's something that we've seen, well, I've seen in the last 2 clinics, and it's properly prepared patients. So in neurosurgery, they had an issue where patients would show up without all the imaging. So what we actually did for them was we built out almost a checklist within the chart, and based on their diagnosis, the PAS would be able to go in there and track where they were with that patient. So if they did have an MRI, where was the MRI? Is it within an EPIC institution and can be pushed, or is it outside and they need to actually request it? And so that framework that we were able to implement, they've actually used it, and we've standardized how the chart scrubbing occurs for the PAS in order to reduce patients showing up without proper imaging or lab results. And in neurology, we've also seen that come up again. And I think certain tools like that can be generalized to other clinics as well.
Yeah, I definitely agree with that. And I think that's the benefit of having a team kind of longer term and making sure that we're informing standard work. My interesting thought around that, though, is, you know, one of the purposes of this is to make sure that we're honoring what the user brings forward as an issue and honoring their buy-in to the solution, right? So now a lot of times when, at least in the 4 that we've done so far and in my work in other programs, you know, you do get clinics that'll say, yeah, we've got this problem. Somebody else must have solved that. And then we can say, oh, yeah, we saw this over in neurosurgery, and this is what we tried. Maybe it'll work here. Maybe it won't, right? But we have to make sure that we get their buy-in to giving that solution a try. And I know that's kind of a fine point, rather than saying, oh, yeah, boy, you screwed that up. Here's your fix. Because then we don't necessarily have their buy-in to the fix. And then yet we've become, again, hi, I'm Bud. I'm here from the government to help, right? We come imposing solutions on them, which is shown not to truly affect burnout. It's actually shown to increase the frustration in the clinical day because they're not bought into the overall solution. If it fails, they have no buy-in to making it better. They say, well, this is another thing Bud threw at us and it didn't work, right? Should probably fire Bud.
Is the idea then to have kind of clinician, informaticists, physicians that really kind of also know how to build their own tools in Epic, kind of embedded in every group or in every clinic? So that they themselves can identify the issues and then become part of the solution by actually helping to build that solution?
We would absolutely love that. We haven't been able to get it funded, right? Because every chair or every department administrator we go to and say, and we tried this a few years ago, say, you should identify a point person. You need to identify a point clinician that's going to collect up all the issues in your department, and you should send them to this training. And they say that's going to take them out of clinical work. Who knows how much amount of time, right? Been estimated 4 hours a month to half their time a month, depending upon the size of the service line and what level they're going to be working on. And so are you going to pay my department for that? And we have been successful here recently in going from about 1.5 FTE of funding for physician informaticists up to about 4 FTE of funding, spread over multiple different specialties. So funding 3 people half their time to funding 7 or 8 people 1 day a week, right? So that's our strategy now. We haven't been able to go into 25 to 30 different service lines and get commitment to have an identified person that's funded in every service line. What we have done is gone from having one adult hospitalist half-time with us, one pediatric hospitalist half-time, and one ambulatory provider half-time, ambulatory specialty provider, I should say, to now having a point person 1 day a week for primary care, one surgeon, one hemonc, one pediatric inpatient, pediatric PICU, pediatric ambulatory, all 1 day a week funded. That makes sense. So we're starting to broaden that out. What I hope to have happen is we broaden that out, we show the outcomes, we refocus them a little bit on this personalization and the one-on-one provider training about helping those other providers that are struggling. We refocus them in that and helping them build tools to support that. And we show the outcomes of the program and we increase the funding. That's what's happened in other organizations.
About the timing question, though, I think you scared me a little bit when you were showing the tech sprint videos, because it was like having a clear calendar for 5 days, and trying to imagine that happening here, even though I'm new, just seems staggering. When you talk to a clinic about wanting to do a sprint with them, what time commitment are you asking them to make available to work with your team? And have you seen some variability in how much time it can take versus, we know if you don't have X amount of time that you're willing to make available, you're probably not going to be able to do a sprint with this group. Does that make sense, the question? Yeah.
Yes. Do you want to answer that, or do you mean to?
What we ask for, it might help if I go kind of how we initiate with a clinic on a sprint. Does that make sense? So what we ask for in the video that Brian showed was fantastic to get the concept of sprint. So rapid cycle test of change, right? We want to go in, find a problem, figure out what we're going to try to do today about that problem, come back tomorrow, talk about what we did today and what we're going to try, or what we did yesterday and what we're going to try today. So that model that was in that video was much more of a system development, application development mindset. We're a lot more operational than that. So it's actually a much shorter, much more varied timeline of what we do during our 2-week sprint. During that 2-week sprint, what we ask for is a 15 to 30-minute huddle. We schedule them at 30 minutes and hope to get done quicker. We don't usually make that, but we hope to get done quicker. We ask for 15 to 30 minutes during either right before or during the clinic day. And then we ask to make sure that when we're going to identify an issue and we're going to spend a little bit of time in the clinic that day, and that time's going to be very variable, right? To figure out what are we going to do today. So usually when we start a clinic on Monday of the 2 weeks, we go in and we take that first huddle and we identify issues. A lot of times that first day is, let's go quantify the issue. One of the interesting things we ran across in neurology was patient delays. One of the highest voted things on their list was we always have patient delays. And so we're like, okay, let's root cause that, right? Let's figure out what it is. So we put some abnormality tracking around it for the first day or two. And we say, when we know we have patient delays, let's go check a box and say, this was physician running late, patient not prepared, whatever those categories are. Come back the next day, look at that and say, well, do we have a root cause that would cause us to do some kind of test of change? And then Tuesday we say, let's say we have providers running late, so how are we going to go address that? And then we just start picking away at that, right? And maybe we address it by making sure that the MA or PAS is keeping an eye on that. When the provider is running late, a little tap on the door, say you've got 5 minutes. Different clinics have approached that in many, many different ways. None of them are usually appreciated by providers, right? But we we give that a try, right? Come to the conclusion and give it a try. So that may take during your clinic day 15 or 20 minutes out of the clinician's time. It may be a little bit more time. We do prep them to say, this is going to be extra work during these 2 weeks, right? You're going to be busy. We've had clinics ask for extra staffing in their MA and PAS from the pool to get more people to help. That's been semi-responsive, right? The pool's been semi-responsive to that. But we do set that expectation that during this 2 weeks' time, you're going to have a little bit more impact, and we need that engagement. Prior to that, what we do and how we engage with a clinic, I have been going and meeting with the practice manager. I initially started out meeting with the medical director, and we determined that that really wasn't successful. Go meet with the practice manager and get the practice manager to set you up with the medical director in the clinical chair. So we meet with the medical director, or the practice manager, medical director in the chair, depending upon how engaged the chair is. We talk about the sprint concept. We get their buy-in. 30 days ahead of the sprint, we schedule time at a faculty meeting. We come to a faculty meeting and do a presentation. We go to a staff meeting and do a presentation. At both of those meetings, we introduce the concept of the sprint, and as soon in that conversation as we can, introduce that concept of we're here to chisel away at those little pebbles in your shoe, of those daily clinic frustrations. Out on the table, I've thrown out a bunch of sticky notes and pens. And I say, as we talk about this the rest of the time, as you think about those frustrations, write them down on a piece of paper, right? Hand them to me or stick them up on the wall on your way out the door. And that's another mode that we use to collect up those issues. So we do a faculty meeting, we do a staff meeting the week before we start a sprint. We schedule another, hopefully combined faculty and staff meeting where we take all those frustrations, we put them up on posters of the wall. We give everybody 5 dots, and we do passion dot voting. So we say, now come through and vote on which one is more important to you as clinics. And the one that gets the most votes, that's what we start with on the next Monday when we start sprint. So that honors them bringing forward the issue, them prioritizing the issue, and then them being at the table to address the issue. We're here to facilitate. And potentially plug you into standard work and evolving standards in the organization. You know, potentially have clinician on a clinician time to sit down and talk about the efficacy of your questionnaires, all of that work, right? But we're there to facilitate. Did that answer your question? Okay. Now, for follow-up, we do, what we're seeing in most of the literature tells us that it's 30 days, we should wait 30 days after an event to do another Maslach burnout. So at that 3 to 4 weeks time frame, we send out the post-survey. That post-survey is another Maslach burnout inventory, and it's a way to collect up their pluses and deltas, you know, of the whole process and get input into the process. We'll take that data, go back to a faculty and staff meeting and present the data. Questions or anything, feel free to shoot me an email.